Then there is many a times you see gelatinous transformation of bone marrow, and aspirations I have seen myxoid background, and the bone marrow are hypocellular. This may be in any of the severe, even iron deficiency anemia. I have seen even in megaloblastic anemia, this type of transformation is seen. This is mostly focal. When it is extensive, then you can get neutropenias or pancytopenias also. As far as aspiration says, there is no one thing that it is advisable everywhere, that there are few advantages of aspiration and few in the bone marrow biopsy. But if both are performed together, yes, you can give a better diagnosis than a single one. There is no sense in quarreling that aspiration is better or biopsy is better, and that Dr. Kamal has already covered. As far as the bone marrow biopsy is concerned, it has a diagnostic value in cases of megaloblastic anemias, leukemias, megaloblastic, of course, when they are frank. Another thing what I have seen is, you are getting megaloblastic picture in the bone marrow, but if you see in the background, you see microcytic picture in the RBCs or lots of piculocytosis and all. Yes, think of MDS. That's what my experience says. Okay? Because when you see megaloblast, we are inclined to give a diagnosis of megaloblastic anemia without going into the details of RBC cytology in peripheral smears. Okay? Of course, multiple myeloma, then lipoid, yes, multiple myeloma also I have told you that reactive plasmacytosis above 30 or 40% I have seen, and that too in my relative. So you have to fulfill the criteria of the diagnosis of myeloma. Otherwise it may be a wrong diagnosis. Yes, cholera and malaria we are all right. Now, these are the conditions where the diagnosis can be suggested, that is aplastic anemia, because invariably in aplastic anemia, what we get is inadequate bone marrow. Yes, if you get fatty fragments, you can definitely. Similar is agranulocytosis, ITP, sideroblastic anemia and hyperplasm. Splenism, a most difficult diagnosis so far, I think. Okay, it is the only suggestive diagnosis. Now, as far as limitations are concerned of aspirations, dry tap, unsatisfactory smears, then focal involvement that Dr. Kamal has already covered, so I will not. And another thing is most dominantly lacking is the stromal changes, that is the diagnosis of myelofibrosis is not possible on aspiration smears. Now, these are the artifacts. Now, if you see at this first photograph, the erythroblasts appear dysmorphic. You can see the projections coming out of the nuclei. This is not a erythroid dysplasia. This is a drying artifact. If the smears are not dried immediately, there is a protrusion of nuclear material in the cytoplasm. This I have done mistake of diagnosis as dyserythropoiesis. But I have found this photograph in one book. Another these are the endothelial cells which are diagnosed as metastatic tumors to the bone marrow because they don't feed in any of these cells. Of course, squamous epithelial, these artifacts you commonly seen in FNSC also because of the finger imprints left on the slides. And lastly, these are the powder artifacts which are commonly seen in pap smear as well as bone marrow. One of my surgeon, he told me that when he is operating, after putting on gloves, he has a practice, or his teachers have taught them to wash the gloves, that no powder remains on the gloves before you operate. Because I have seen a case suffering from these granulomas. Okay? This case was operated because of pain in abdomen. Then the pain was never relieved. She was taken to the expert, re-operated, and what they found is sclerosis of the mesentery. And this develops very fast. Whenever the patients are, as far as we are concerned, we only have problems in diagnosing. But as far as anybody who has seen this powder, they can not miss it. Okay, thank you very much for the question.